has presented us with the 5-day history of fever, which was 2 weeks back, which was treated outside as enteric fever. After that, she has developed complaints of dizziness, which is episodic. She feels like a spinning movement of herself, but is not associated with any position change of the head. She also since then complained of swaying while walking with history of recurrent falls. She also gives history of episodic slurring of speech with altered sensorium. However, there is no loss of consciousness, no blurring of vision or double vision, and no further fever episodes during the event. She past history wise, she had one episode of generalized tonic-clonic seizures 2 months back, 2 months after her second pregnancy, and has been on phenytoin 100 mg BD for the past 15 years, for which she is not getting evaluated. On examination, her vitals were all stable. General examination was normal. On systemic examination, CNS examination, she had an gaze-evoked horizontal nystagmus, which later on further evaluation, the next following day, she has developed into a spontaneous nystagmus. Otherwise, the rest of the cranial nerve examination was normal. Motor and sensory system examination is normal. The reflexes were 3-plex in all the limbs, and she has signs of cerebellar dysfunction. She has positive past pointing, and also dysdiadochokinesia bilaterally, and rhombus is positive. So, summarizing, a 44-year-old lady who's known case of a seizure disorder on phenytoin, presented with history of dizziness, with unsteady gait, with episodic slurring of speech, and examination she was found to have nystagmus and positive cerebellar signs. So the first thing we have considered was phenytoin toxicity, because she is on phenytoin for 15 years. This was the first differential. The other one is because she had a history of fever 2 weeks back, we have also considered possibility of acute viral cerebellitis. The other differential we have considered was post-infectious syndrome. The thing we have considered was a posterior circulation stroke, and later down differential we have also considered vitamin B12. So initial investigations are all normal. There is no renal dysfunction or there is no hepatic dysfunction, and the CT and MRI brain was done, which was normal. We have sent a phenytoin assay, which was more than 40, and hence we have made a diagnosis of phenytoin toxicity. So I like to talk about phenytoin toxicity. Now, phenytoin, as we know, is one of the most common anti-epileptic agents we use. It is used both for partial as well as complete seizures, but however, we do not use for absent seizures. How does it act? It acts by the blockage of the voltage-gated sodium channels. And phenytoin has a narrow therapeutic index. The normal range is around 10 to 20. So regular monitoring of phenytoin is required. If there is any overdose of oral or IV phenytoin, can cause both neurological as well as cardiotoxicity. Neurotoxicity is manifested in the form of cerebellar symptoms, whereas cardiotoxicity in the form of arrhythmias. They can have a prolonged QT interval. So it can also cause other complications like purple glove syndrome, and can also cause folate and deficiency and peripheral neuropathy. Side effects that can occur with phenytoin toxicity are gingival hypertrophy, hirsutism, and nodular skin lesions. So this is a approximate normal ranges of the phenytoin, and if usually 10 to 20 is considered normal. If more than that, they can present with nystagmus. If it is more than 20, they present with nystagmus. If it is more than 30 to 40, they are present with ataxia, tremors, and vomiting. If more than 40 to 50, they are usually present with lethargic, confusion, and hyperactivity. And if it's more than 50, they are present with coma and seizures. So our patient has presented with more than 40. However, she didn't have any features of lethargic, confusion, or hyperactivity. She has only ataxia, slurred speech with nystagmus. So there are many case reports of phenytoin-induced cerebellar syndrome. So this is one case report that has been published. This case report, according to this case report, they have not given the patient any medications. They have just supportively managed the patient, and over a week, the patient's symptoms have improved. According to the study, they also emphasize there is a regular monitoring of plasma drug concentration is required because of its narrow therapeutic index. We know that phenytoin is an enzyme inducer, and it is metabolized in the liver by cytochrome enzymes. So any drugs that can inhibit cytochrome can cause toxic levels of phenytoin. So that's why if the patient is on phenytoin, we should carefully evaluate what antibiotics or what other medications should be given so that we should not cause a phenytoin toxicity. The other thing is hyperalbuminemia also can cause elevated phenytoin levels, and the reason is more than 90% of the phenytoin is usually bound to albumin. And if there is hyperalbuminemia, there will be increased free phenytoin, which can cause phenytoin toxicity. So what is the usual care of treatment for patients who present with phenytoin toxicity? There is no specific antidote as such, but the management would be supportive care, change of anti-epileptics. The other thing that we have considered is giving a multi-dose activated charcoal. So the purpose of giving a multi-dose activated charcoal, it's not a specific treatment for phenytoin. It is still controversial, but some studies show that because phenytoin has an enterohepatic circulation, giving a multi-dose activated charcoal will reduce the phenytoin half-life, thereby reducing the symptoms. So this is one of the study that has been done, which shows the use of multi-activated charcoal in phenytoin toxicity. So as we can see, they have taken 3 patients who have presented with phenytoin toxicity. If you can see the triangle boxes is the patient who has received the multi-dose activated charcoal in 20 hours presentation, whereas the square box is the patients who have received 60 hours, and round circle one are the patients who have not received the multi-dose activated charcoal. So in who have not received the multi-dose activated charcoal, their phenytoin levels are still on the higher side, whereas the patients who have received it, there is a drop in the phenytoin levels. And so according to this study, it's saying it's showing beneficial to give multi-dose activated charcoal in patients with phenytoin toxicity. So in our patient also who has presented, we have given multi-dose activated charcoal for 3 days, post which her symptoms have resolved and there is a reduction in phenytoin levels, and hence she was discharged. Thank you.
Thanks, Sharon. Are there any questions from the audience? This lady, if I'm not wrong, in the ward, she had been on phenytoin with these severe cerebellar symptoms for many months, and she was completely bedbound. And even after we stopped the phenytoin, firstly, it took a long time for the levels to normalize. And even after we stopped it, her cerebellar signs did not actually fully resolve. So it was like some permanent neurological damage she had, which was quite tragic, such a easily correctable illness, but it had been many months before it was actually diagnosed. I also remember that when I was a postgraduate in neurology and we used to go and see seizure patients in casualty, I used to find that many people used to have cerebellar signs, including nystagmus, and it would be after that 900 mg loading dose of phenytoin that everyone uniformly gets. So even at that time, I mean, I suppose, you know, there may not be long-term effects of that, but it's certainly something to think about whether the loading dose is correct for everyone. And also there are probably safer anti-epileptics that are available. It's not really a first choice anti-epileptic, though of course the cost is always the thing that makes us choose it, because people have to be on really long therapy with it. But obviously it has a lot of risks, and in rare cases, if you've not stopped it, you don't stop it fast enough, obviously there's some permanent neurological damage as well. Actually, most people seem to recover, but I think this was a specific lady that for so many months, it was so high. In fact, her phenytoin levels were more than 40. We don't know how much. It could have been something really, I don't know, a lot, but it was for many months. She was completely bedbound for 3 months before she came, and probably that toxicity had been going on for years. I know I didn't read at the time. I didn't read anything about it being reported, but just that her cerebellar signs didn't fully recover.
You were able to check the literature as to long-term damage.
I haven't seen any literature on.
When I had looked at it at the time, I didn't actually find anything, and we were kind of expecting her to recover, and kind of telling the family as well that, you know, we hope it's drug induced and it should get better.
What kind of seizures did she have?
She had a generalized tonic-clonic seizure.
It was many years ago. It was like 20 years.
Yes, one
or two. Okay.
That is a different patient.
This is a different patient. Okay. Well, there was a. Yeah. Oh, okay.
Okay, sorry, Sharon is telling me it's a different patient, but we did have the cerebral, a second patient. So this is a second
The
patient.
second patient.
So yeah, in that case, we did look for cerebellar disease as well. Initially, we did, and it was MRI imaging was normal. Yeah.
She has presented with an acute over a day period. Her presentation was over days, not months.
Sure. Thank you, Sharon. So that concludes the clinical meeting for today. Thank you to all our presenters and everyone who's come to watch. This prize for the best presentation goes to Alcy.